Hello there, my valued and treasured viewers and listeners, and welcome back to our Pharmacotherapy MCQ series to part 13. My name is Dr. Nath Arwa, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector, especially those based in hospitals. This is the Virtual Pharmacy Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. At Progressive Pharmacotherapy Consultants, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So, I urge you to sit back and spare me part of your precious time to share some tips with you. So, welcome. So, our first case is C.K.M, a 52-year-old white patient working at the American Embassy in Nairobi who underwent thyroidectomy at the Aga Khan University Hospital in Nairobi for the treatment of a follicular thyroid cancer 3 months ago, to be specific. Now, this patient reports to the hospital for a routine appointment, and he has no current complaints. Surgery went well. So the labs include an FT of 1.5, where the suitable range should be anything between 0.4 and 1.4 nanograms per deciliter. The thyroxine T is 180. The range is anything from 84 to 172, and his TSH is 0.12 million units per liter, and the acceptable normal range is 0.4 to 4 million units or mega units per liter. CKM is currently on 175 micrograms of levothyroxine taken after breakfast once daily. Now, the resident on duty at your clinic requests your assistance in interpreting the above laboratory results because the endocrinologist and the surgeon who participated in the procedure have agreed to prescribe levothyroxine at that dose. Now, based on the patient's history and his current presentation, what do you recommend to the resident on duty who is unsure whether the dosage is correct? Would you tell him that CKM's TSH is below normal, his FT is higher than normal, therefore the dose of levothyroxine should be decreased to 150 micrograms taken orally once a day after breakfast? Or would you tell him the TSH is below normal, the FT is higher than normal, therefore the dose of levothyroxine should be increased to 200 micrograms taken orally after breakfast? Or should you tell him that CKM should be switched to a T product because this will best prevent recurrence of his thyroid cancer? Or finally, would you tell him that the TSH is at goal, and because he isn't complaining of any symptoms or adverse effects, he should be maintained on his current dose? So I'll give you 10 seconds to choose the correct explanation to the resident. So let's move to the slide with the correct answer. In my opinion, the correct explanation I would offer the unsure resident is D. The typical management of patients with papillary thyroid cancer is thyroidectomy. That's recommended, and that can be followed by an RAI and thyroxine replacement therapy. As TSH stimulated the growth of abnormal thyroid cells, including the papillary thyroid cancer, the T dose in these patients are intentionally dosed high to decrease TSH levels to between 0.1 and 0.2 million units per liter. It's called T suppressive therapy, to be specific. Now, this minimizes the likelihood of cancer recurrence. Remember, we've done surgery. Because this patient is biochemically hyperthyroid but symptomatically euthyroid, answer D is the correct answer. While high enough doses of T can suppress the TSH level, it would be most likely to cause him to be symptomatically hyperthyroid, since T has a short half-life, which can result in supraphysiologic hormone levels. So that explains why D would be our best explanation to the residents. Let's move to the next slide. MMM is a 24-year-old obese white British woman working at the British Embassy in Nairobi with a history of POCS and prediabetes, and she presents to the Nairobi hospital with complaints of inability to conceive. The husband desires to have a son at this moment, and she also complains of glucose intolerance. Because she really desires to conceive, which of the following therapies is best to recommend for the management of the POCS, that is a thorn in her flesh? Would you opt for eflornithine, or metformin, or finasteride, or would you go for spironolactone? I'll give you 10 seconds to make the correct choice. In my opinion, B is the correct answer. Now, 3 of the agents listed above are anti-androgenic agents. So I'll start with eflornithine, which is in answer B. It blocks ornithine decarboxylase, which slows hair growth, because this enzyme is required for growth differentiation of hair follicles, and it's therefore very helpful in the management of hirsutism, not POCS. So it's the wrong choice. The next one is finasteride in answer C, which is a potent anti-androgen, and it's a 5-alpha reductase inhibitor, to be specific. It reduces peripheral conversion of testosterone into DHT, the active androgen metabolite. Now, spironolactone in answer D is an androgen receptor inhibitor, and it improves hyperandrogenic manifestations of POCS. Now, contraception is required when spironolactone or finasteride are used because of the potential for feminization in male infants in case the woman conceives while on them. Metformin, in my opinion, is the correct answer. It's an insulin sensitizes insulin in the liver, which improves glucose intolerance. Its use may be associated with weight loss, and it may improve the lady's menstrual regularity, thereby increasing her fertility. Now, it's established in literature widely that metformin is safe to use during pregnancy. So metformin would sort our worried patient correctly. So let's move to the next slide. Metformin is the correct choice for the POCS. The next question reads, why is bromocriptine preferred over cabergoline in the treatment of hyperprolactinemia during pregnancy? Is it because it's safer, or is it because it's more D2 specific, or is it because it's better tolerated by the ladies, or is it because it's more effective? I'll give you 10 seconds to make the correct choice. So in my opinion, it's preferred because it's a safer option. Now, prolactin secretion by the anterior pituitary is predominantly under hypothalamic inhibitory control through the release of dopamine. Bromocriptine and cabergoline are D2 agonists which stimulate postsynaptic dopamine receptors in the hypothalamus, thereby directly inhibiting prolactin secretion. While cabergoline is a more D2 specific and therefore is better tolerated and more effective, bromocriptine is preferred in pregnancy because of its historically long record of safety when used in pregnancy, unlike cabergoline. So let's move to the next slide. That is the reason why it's a better option. So B.O.B was recently diagnosed with Addison's disease and was initiated on oral hydrocortisone. Now, which of the following statements is correct regarding adrenal replacement therapy? Is it exogenous steroids such as hydrocortisone and preferred treatment of choice for Addison disease, and B.O.B should be switched to mitoten? Or is it B, during an illness associated with vomiting, B.O.B should receive a parental glucocorticoid? Or is it C, during illness, B.O.B should be instructed to cut his daily hydrocortisone dose? Or is it most of the day's steroid dose should be administered in the evening to mimic endogenous cortisol circadian rhythm secretion? I'll give you 10 seconds to choose the correct answer. So I'll go straight to the slide with the correct answer. In my opinion, answer B is correct. Now, patients with Addison's disease are unable to mount the appropriate adrenal response during times of physiologic stress that patients with normal adrenal functioning are capable of doing. Exogenous steroids are the preferred treatment option for Addison disease, and patients are advised to double or triple, not to cut, to double or triple their usual steroid doses during such episodes to avoid going into what we call adrenal crisis. Now, if the patient is vomiting, he or she should immediately go to the nearest hospital for what we call parenteral steroid replacement therapy. The hydrocortisone should be administered parenterally by injection. And that is if they do not have such access within the confines of their home. Now, mitoten is wrong because it's indicated in Cushing's syndrome, which is an adrenocortical carcinoma. Now, its use in Addison disease would only exacerbate the adrenal crisis. So, to mimic what we call endogenous circadian rhythm of cortisol secretion, the majority of a glucocorticoid dose should be taken in the morning, not in the evening. So that leaves us with B as the correct answer. Let's move on to the next question. Mrs. K.M.M. is a 55-year-old white lady who presents to a clinic for cardiovascular risk management. From history, you tell she's hypertensive. She's currently on amlodipine, which she takes at a dose of 10 milligrams orally once a day. At the clinic, her blood pressure is 128 systolic, 78 diastolic. She has a heart rate of 75. Her TC is 200. Her LDL cholesterol is 122. So my question to you is, what is the most appropriate recommendation for the use of antiplatelet therapy for primary prevention of coronary heart disease in our dear lady KMM? Would it be antiplatelet therapy is not recommended at this time? Or is it aspirin 81 milligrams orally once a day? Or is it aspirin at a higher dose of 325 milligrams orally once a day? Or is it clopidogrel 75 milligrams taken orally once a day? I'll give you 10 seconds to choose the correct answer. In my opinion, A is the correct answer. Antiplatelet therapy isn't recommended at this stage. The 2016 U.S. Preventative Services Task Force guidelines on aspirin for preventing cardiovascular disease and cancer recommends low-dose aspirin, that is 81 milligrams per day to be specific, for patients aged 50 to 59 years who have a 10-year ASCVD risk of 10% or more, and who aren't at an increased risk of bleeding. And this person should also have a life expectancy of at least 10 years, and they should be willing to take the low dose aspirin for at least 10 years continuously and be or remain adherent to it. In addition, the 2019 ACC/AHA guidelines for primary prevention of cardiovascular disease state categorically that low-dose aspirin can be considered for adults aged 40 to 75 years and at a higher ACVD risk who aren't at a risk for bleeding. Although this patient is older than 50, her 10-year ASCVD risk is below the figure of 10%. Now, her risk of GI bleeding is likely to be higher than the risk of cardiovascular events. Now, that makes antiplatelet therapy inappropriate for this patient. In addition, Clopidogrel is used only for primary prevention in patients who are allergic to aspirin. So that makes choices C, B, and D incorrect. I would settle for choice A. Let's move to the next question. And it reads, JIL, a 51-year-old male patient with a medical history significant for type 2 diabetes mellitus, hypertension, hyperlipidemia, and an MI which he experienced 2 years ago, presents for treatment of the dyslipidemia at the cardiology clinic in your hospital. Currently, he is taking metformin at a dose of 1 gram orally twice a day after food to manage his diabetes mellitus type 2. He also takes high intensity atorvastatin at a dose of 80 milligrams at night, and he's on aspirin prophylaxis at a dose of 81 milligrams orally once a day. He takes carvedilol at a dose of 25 milligrams orally twice daily, and he's also on lisinopril 40 milligrams orally once a day. Now, on probing, he tells you he's adherent to all his medications, and informs you that he follows a heart-healthy diet. He has taken responsibility for his condition. His fasting lipid panel shows the following: a TC of 175, a TG of 185, HDL of 40, LDL of 98, which was 186 at baseline before he started dieting and taking in high intensity atorvastatin, and the non-HDL is 134. So my question to you is, what recommendation would be most appropriate for management of JIL's hyperlipidemia? At the moment, would you make no changes? Is the correct answer no medication changes are recommended? Or would you initiate ezetimibe at a dose of 10 milligrams orally once a day? Or would you initiate cholesevelam 1875 milligrams taken orally twice a day? Or would you initiate evolocumab at a dose of 140 milligrams administered subcutaneously every 2 weeks? I'll give you 10 seconds to make the correct choice. So personally, I would settle for ezetimibe taken at a dose of 10 milligrams orally once daily. According to the AHA-ACC cholesterol guidelines, this particular patient has a very high ASCVD risk because he has one major event, which is the MI he had 2 years ago, and several high-risk conditions. He's diabetic type 2 and is hypertensive as well. Now, in patients with very high risks of SCVD, these guidelines suggest using an LDL threshold of 70 and considering adding non-statin therapy to maximally tolerated statin therapy. Remember, he's already at maximum of 80, so it's time to add another second agent from a different class. This patient's LDL is above that threshold of 70 that we just talked about. Therefore, it would be reasonable to add a non-statin therapy at this stage. The guidelines recommend ezetimibe as the first non-statin therapy to be added onto a statin. The bile sequestrants are recommended only if the patient is intolerant to ezetimibe and the TG are less than 300. Adding a PCSK9 inhibitor would be reasonable if a patient were taking maximally tolerated statin therapy plus ezetimibe. Remember, we've not yet gotten there. And such a patient should also have an LDL of 70 or greater, or the non-HDL should be 100 in that particular case or greater. So these PCSK9 inhibitors are recommended after ezetimibe because ezetimibe is more cost effective than they are. So I would opt or settle for the addition of ezetimibe at a dose of 10 milligrams taken orally once a day, in addition to the 80 milligrams of atorvastatin that the patient takes at night or at bedtime. Let's move to the next slide. Patient CPD is a 48-year-old black man who presents to your cardiology clinic for hypertension management. He is 5 feet 10 tall and weighs 100 kilos. His BP at the clinic is 136 systolic, 82 diastolic, and you let him settle down and repeat the measurements. The repeat one is 138/85. He has a heart rate of 58, pretty low. And he currently takes 40 milligrams of lisinopril once a day. He's on chlorthalidone, 25 milligrams orally once a day, and he takes 10 milligrams of amlodipine, 10 milligrams once a day. And he reports adherence and he tolerates his medications very well. His pertinent labs are, the potassium is on the higher side, but still within the range of 3.5 to 5.5. It measures 4.2 millimoles per liter. His creatinine clearance is 85, which is the best therapeutic plan for our patient CPD at this visit. Should you initiate metoprolol succinate at a dose of 50 milligrams once daily orally and monitor his BP, his heart rate in 30 days? Or should you initiate spironolactone at a dose of 12.5 milligrams once a day in the morning and monitor the serum creatinine and the potassium levels in 3 days' time? Or should you increase his lisinopril dose to 80 milligrams once daily and monitor his serum creatinine and potassium levels in 2 weeks' time? Or should you finally discontinue the diuretic chlorthalidone and replace it with hydrochlorothiazide at a dose of 25 milligrams taken orally once a day? I'll give you 10 seconds to choose the correct answer. But the best option, in my opinion, would be to add an spironolactone at a dose of 12.5 orally once a day in the morning. And because it's potassium sparing, it would be in order to monitor the levels within 3 days to avoid a case of hyperkalemia. Now, according to the 2017 ACCHA hypertension guidelines, this case meets the criteria for resistant hypertension because the patient is taking 3 agents at optimal doses, and one of them is a diuretic. The guidelines recommend a BP goal of less than 130/80 in patients with confirmed hypertension. Although it would be appropriate to recheck the serum creatinine and potassium within 1 to 2 weeks of initiating an angiotensin converting enzyme inhibitor, increasing the lisinopril dose to 80 once a day might not significantly reduce his blood pressure, but it might increase risks of adverse drug reactions. Now, according to the 2018 AHA scientific statement for resistant hypertension recommendations, adding a mineralocorticoid receptor antagonist after clothalidone would be appropriate. Therefore, spironolactone would be the most appropriate addition at this stage, and the serum creatinine and the potassium serum levels should be monitored within 72 hours of initiating the spironolactone. Now, beta blockers can be considered after therapy with an aldosterone antagonist, and clothalidone is more potent than hydrochlorothiazide, and it's the preferred diuretic according to the 2018 AHA scientific statement. So that makes answers C, B, and A wrong. Let's move to the next question. Our patient U.K.M. is a 77-year-old patient with a medical history significant for peripheral artery disease. He also has dyslipidemia and is currently taking 81 milligrams of aspirin orally once a day for prophylactic purposes because of the PAD. What is the best recommendation for U.K.M's dyslipidemia? Would you initiate atorvastatin 80 milligrams, that is a high intensity dose, at night, or would you opt for pitavastatin 2 milligrams at night and repeat the lipid measurements in 2 months' time, or would you opt for 20 milligrams of lovastatin taken at night and repeat the lipid measurements in 6 months' time, or would you go for a high-intensity rosuvastatin at a dose of 40 milligrams at night and repeat the lipid measurements in 2 months' time? I'll give you 10 seconds to settle for the correct answer. So I would prefer pitavastatin at a dose of 2 milligrams taken at bedtime, and I would repeat the lipid measurements in 2 months' time. The ACC-AHA guidelines would classify this particular patient as being in statin benefit group 1 because of the presence of clinical ASCVDs, which is PAD to be specific. He is considered to have stable ASCVD because he doesn't have any history of several major ASCVD events or one major ASCVD event plus several high-risk conditions. Now, because he's above the age of 75, moderate intensity statin therapy is recommended, and that makes pitavastatin a suitable choice. Now, you can tell atorvastatin at 80 and rosuvastatin at 40 are high intensity doses. That makes them incorrect, and option C is low intensity statin therapy. So I would settle for option B. Now, a repeated lipid measurement should be done anywhere from 4 to 12 weeks after initiating statin therapy or after titration, and then from then on we do it when necessary every 3 to 12 months according to the guidelines that I've just quoted earlier. Let's move to the next slide. So it asks, which therapy would be best to recommend for patients being discharged from hospital after STEMI who received a DES who have no contraindications whatsoever? Would it be aspirin at a dose of 81 milligrams once a day together with 75 milligrams of clopidogrel, both taken orally once a day? Or would it be a dose of 81 milligrams of aspirin and 10 milligrams of prasugrel, both taken once daily orally? Or would it be 325 milligrams of aspirin alongside 90 milligrams of ticagrelor, both taken orally once a day? Or would you opt for 325 milligrams of aspirin alongside 75 milligrams of clopidogrel, both taken orally once a day? I'll give you 10 seconds to choose the correct answer. In my opinion, B is the correct answer. I would recommend 81 milligrams of aspirin alongside 10 milligrams of prasugrel taken orally once a day. According to the 2016 ACC AHA guidelines, focused update on the duration of dual antiplatelet therapy DAPT in patients with CAD. DAPT is recommended in patients with a STEMI receiving a drug-eluting stent. The aspirin dose recommended is 81 orally once a day, and prasugrel is recommended over clopidogrel on the basis of the Triton TIMI 38 trial. I would recommend you look for the related article and read more on this. Let's move to the next question. AKL is a 67-year-old male patient with the peripheral arterial disease with intermittent claudication. He is currently taking 40 milligrams of atorvastatin at bedtime, 81 milligrams of aspirin orally once a day, and in the morning after his breakfast, he takes 12.5 milligrams of hydrochlorothiazide. His BP is as shown, 130 systolic. All his lab values are within normal limits. So what additional therapy would you recommend for AKL's intermittent claudication? Would it be 75 milligrams of clopidogrel taken orally once a day? Would you settle for cilostazol at a dose of 100 milligrams every 12 hours orally? Or would you settle for pentoxifylline at a dose of 400 milligrams every 8 hours orally? Or would you prescribe rivaroxaban at a dose of 20 milligrams orally once a day? I'll give you 10 seconds to make the correct choice. So personally, I would settle for cilostazol at a dose of 100 milligrams taken orally every 12 hours. According to the 2016 AHA ACC guideline on treating patients with the PAD, antiplatelet therapy is recommended, but anticoagulant therapy isn't. Using the dual antiplatelet therapy with clopidogrel and aspirin is recommended only in the presence of revascularization. Remember that. And cilostazol is recommended for patients with intermittent claudication, while pentoxifylline is not, according to that particular literature. So that leaves us with the B as the correct answer. Let's move to the next question, which reads, J or J is a 69-year-old man who has had an NSTEMI with a drug-eluting stent placement. That was done 8 months ago. He is scheduled to undergo an elective CABG procedure according to your thoracic surgeon, cardiothoracic surgeon. Things didn't go well with the PCI and they want to proceed and do CABG. He's currently on 81 milligrams of aspirin orally once a day alongside 10 milligrams of prasugrel orally once a day. He has normal renal and hepatic functions. So how would J.O.J's antiplatelet therapy best be managed for this surgical procedure that you've electively planned? Would you discontinue both prasugrel and aspirin now, or would you discontinue both of them 5 days before the planned CABG, or would you continue with the aspirin but discontinue prasugrel 7 days before CABG is done? Or finally, would you continue with aspirin and discontinue prasugrel 5 days before CABG is done? I'll give you 10 seconds to ponder over it and make the right therapeutic decision so that our outcomes of the surgery are optimal. So the correct answer according to those guidelines is C. Aspirin should continue, but prasugrel should be discontinued a week prior to the CABG. According to the AHA, ACC, and STEMI guidelines, patients with past acute coronary syndrome who are transitioning to surgery can continue with aspirin, but the P2Y12 inhibitor, like prasugrel in this case, should be discontinued 7 days prior to surgery for prasugrel and 5 days prior to surgery for clopidogrel. That makes D the wrong answer, A and B the wrong answers, and it leaves us with C as the correct answer for this particular case. So let's move to the next slide. ASJ is a 66-year-old man who recently had a minor ischemic stroke, and on the National Institution of Health stroke scale he scored -2. He was discharged on 81 milligrams of aspirin alongside 75 milligrams of clopidogrel. He takes both orally once a day. During a follow-up clinic visit a week later, he denies bleeding or any symptoms of stroke or transient ischemic attack, TIA. So which of the following regimens would be most appropriate for preventing recurrent stroke or TIA in our patient ASJ? Would it be continue aspirin and clopidogrel indefinitely? Would it be continue aspirin and clopidogrel for 30 days and then discontinue aspirin, and then continue aspirin indefinitely but discontinue the clopidogrel? Or would you continue both for 6 months and then continue clopidogrel indefinitely but discontinue aspirin? Or would you discontinue both and replace them with rivaroxaban and administer that indefinitely? I'll give you 10 seconds to make the correct choice. So I would settle for B. I would continue aspirin and clopidogrel for a month and then discontinue clopidogrel but continue with aspirin from then on. Now the ASA guidelines for the early treatment of patients with acute ischemic stroke state categorically that in patients with minor stroke such as this one, treatment with a combination of aspirin and clopidogrel for 3 weeks, which began within 24 hours, can be beneficial for secondary stroke prevention for up to 90 days from the symptom onset. Now, after that, patients should continue monotherapy, not dual therapy. This recommendation is based primarily on the CHANCE trial, CHANCE trial, which showed a reduction in recurrent stroke at 90 days with a short-term combination therapy compared with monotherapy. Now, a more recent trial called the POINT trial, POINT, compared clopidogrel plus aspirin for 90 days with aspirin monotherapy. And it also showed a reduction in recurrent ischemic events, but had a significantly increased risk of major hemorrhage. So the benefit of DAPT, dual antiplatelet therapy, occurred mainly in the first 30 days, according to that trial, whereas bleeding risk increased over time. Now, considering both trials, it would be reasonable to continue short-term dual antiplatelet therapy for 30 days and then continue monotherapy indefinitely. So long-term dual antiplatelet therapy does not reduce risk in patients with stroke or TIA, but it does increase the risk of bleeding. So oral anticoagulant therapy is not recommended for TIA, for the ischemic stroke, but it would be appropriate for patients with cardioembolic stroke caused by non-valvular AFib. And because of that, I would settle for option B. My trusted, cherished, and highly esteemed viewers and listeners, that brings us to the end of this part of our Pharmacotherapy MCQ series. I highly appreciate the fact that you sacrificed and made time to interact with me in this session. And if this video helped you in any way, I would like to urge you to remember to like it and to subscribe to my YouTube channel if you haven't done so. So I would like to promise you that the best is yet to come. I hope to interact with you in the next session of our Pharmacotherapy MCQ series. So thank you very much for making time to be here.